Good afternoon, everyone, and welcome. Bienvenue à tous et à toutes to our first Post-Pediatric Days webinar series. Today, we're focusing on a question that many clinicians working in humanitarian and resource-limited settings know all too well. How do we safely manage severe dehydration in children with severe acute malnutrition? For decades, this has been an area where guidance has been based on limited evidence, despite the fact that these children are amongst the most fragile patients we care for. That's why it's a real privilege to open this series by discussing the landmark GastroSAM trial, which provides much needed data to help guide clinical practice. Although the GastroSAM trial is often referred to as a single study, it actually includes two trials. There's the GastroSAM A, which compared different IV rehydration regimens with oral rehydration for severe dehydration. The results of this trial were published in the New England Journal of Medicine last year. And GastroSAM B, which compared Resemal with standard low osmolarity ORS. We're very excited to announce that these results were published in The Lancet today. Before I introduce you to our speakers, I'd like to start with a short poll of current practice for managing dehydration in patients with severe acute malnutrition. So if you could all pull out your smartphones, and I'll ask Mariana to load our poll questions. In children with severe acute malnutrition, estimating the degree of dehydration using clinical signs is reliable. Do you agree, strongly agree, disagree, or strongly disagree? Pour les francophones, chez les enfants atteints de malnutrition aiguë sévère, l'estimation du degré de déshydratation à partir des signes cliniques est fiable. Est-ce que vous êtes d'accord or pas d'accord? Okay, so most of us think that it's actually quite difficult to estimate degree of dehydration using clinical signs. For our next question, for a child with severe acute malnutrition and gastroenteritis with severe dehydration, what is your current practice for rehydration? Pour un enfant avec les malnutritions aiguës sévères et des gastroentérites avec des déshydratations sévères, quelle est votre pratique actuelle en matière de réhydratation? Do you rehydrate with oral or nasogastric fluids, a combination of IV and oral or nasogastric fluids, or using IV fluids? The majority of people actually use IV and oral, a combination of IV and oral and nasogastric fluids. Some use IV fluids and some use oral and nasogastric. We'll move on. Thank you. So in your facility, which of the following oral solutions is used to rehydrate a child with severe acute malnutrition and gastroenteritis? So which of the following do you actually do, regardless of what you'd like to do? Do you use Resemal, ORS? Does it depend on the clinician treating the child? Or other solutions such as water or homemade solutions? So sometimes it may be a matter of access or a matter of preference. You can respond as to which of the following. So, dans votre établissement, laquelle des solutions orales suivantes est utilisée pour réhydrater un enfant atteint de malnutrition aiguë sévère et de gastroentérite? Okay, so we're seeing that the majority are using Resemal for children with acute malnutrition for oral rehydration. And the final question for you, this is a word cloud, so you can add a word or one or two or three words. What is the biggest challenge in managing severe acute malnutrition and diarrhea? Donc, quel est le plus grand défi dans la prise en charge de malnutrition aiguë sévère et la diarrhée? In English or en français? So lots of different responses there. The words that make up the bigger in size, more people have responded. So we're seeing a lot of concerns around shock, around fluid overload, clinical monitoring, rehydration, overload. So that's a big concern that's mentioned a number of times. Fluid management, surveillance, complications. Really interesting to see what people's experiences are in this area, and hopefully some of those concerns will be addressed throughout these presentations today. So thank you all for sharing your responses. It's always fascinating to see the range of different responses and different practices for those of you working in these settings. It's now my pleasure to introduce the speakers for this event. So I start by introducing Professor Kathryn Maitland, Professor of Paediatric Tropical Infectious Diseases at the Imperial College London. Professor Maitland is based full-time in East Africa, where she leads important research, including large phase 3 trials aimed at reducing childhood mortality in resource-limited settings. She was the lead investigator of the landmark FEAST trial, which examined the effects of fluid bolus therapy in critically unwell children in African settings, and this prompted reflection globally on fluid therapy in children in both resource-poor and resource-rich settings. Professor Maitland is the principal investigator of the GastroSAM trial, and she'll today walk us through the rationale for the study and present the key findings from both trials. Kath, it's a real pleasure to have you with us today.
Thank you.
We have Dr. Elizabeth George, Principal Research Fellow and Senior Statistician at the MRC University College London. Dr. George is a seasoned researcher whose work focuses on clinical trials of acutely unwell children in Africa. She was the trial statistician and co-investigator for the GastroSAM trial, and she'll present the trial design, enrolment and adherence for both the IV and the oral arm. Hi, Lizzie. Thanks for joining us.
Thanks very much, Johanna.
Dr. San-Maurice Ouattara, clinician and epidemiologist with Epicentre, Médecins Sans Frontières France. He's a co-investigator for the GastroSAM trial on the Niger site. Having lived and worked in the settings in which this trial was implemented, Dr. Ouattara is very familiar with the challenges healthcare workers face when managing sick children with severe malnutrition. He'll provide insights into the coordination and implementation of the research in these extremely challenging contexts. Bienvenue, welcome, Dr. Ouattara.
Hello, thank you.
And very happy to welcome Dr. Roberta Petrucci, paediatrician and public health specialist in Geneva and principal investigator of the GastroSAM trial. Dr. Petrucci brings more than 20 years of experience working in humanitarian settings. She's had multiple roles within Médecins Sans Frontières, including as clinician, medical coordinator, and pediatric technical referent, and she led the pediatric working group for 6 years until 2024. Drawing on her experience in research, guideline development, and her deep understanding of the realities of the context in which we work, Roberta will discuss the practice and policy implications for the results of the 2 trials we'll hear about today. Roberta, very nice to see you again.
Thank you very much, Johanna.
So thank you. And with that, I hand over to Professor Kathryn Maitland. Kath, yours.
Thank you very much. Just checking everybody can see this. So it's a real pleasure to be able to present this today, and I just thank the organisers for pulling together such a fantastic event. I'm very, very interested to see some of the responses to the initial questions. So I've spent the last 26 years in Africa, focusing on the actual immediate treatment of critically sick children. If you're trying to think about, how are you going to save children's lives? I think people think about vaccines, about sanitation, etc. But actually, the clinical decisions that you make in the hospital in the first few hours and the treatments that you give them can, obviously for many critically sick children, can determine their outcome. Some were good outcomes and some with bad outcomes, but quite a lot of the evidence, and this is not just unique to low-income settings, this is unique around the world. Many have very strong recommendations, but they haven't been tested in clinical trials. And the only really way to test them is to do control trials of these of major interventions that you give in the emergency room. So let's just turn to gastroenteritis. This is a general point that actually it's still incredibly common. The UNICEF estimates about 2.5 billion cases worldwide, and it remains the second biggest killer of children. Studies have shown, very detailed studies have shown that actually in lower to middle income settings, children who are admitted with gastroenteritis are 8.5 times more likely to to die than those who don't have. A lot of the deaths will occur within the first 7 days of admission, suggesting that maybe this might be something in the immediate management or that early management that might not be working in the first place. One of the key risk factors for those early fatalities is the nutritional status of the child. In other words, children who are undernourished or malnourished are a major risk factor for poor outcome. So we set about looking at the actual evidence, and this is the evidence for guidelines worldwide. This is not children who have severe malnutrition. So given the fact that there is absolutely loads of gastroenteritis, we were very, very surprised to actually find the actual rehydration, which is actually very, very liberal volumes that are being given, that there's only ever been 3 studies, in total 464 patients. None of them were conducted in LINCs, and none of them there were any deaths. So despite all of the burden of disease and very little evidence has been generated for the recommendations. We're now going to turn our focus on to severe malnutrition, going forward, labelled SAM. So these are some of the most critically sick children that come into hospital. They are very, very fragile, and they obviously need good supportive care. The supportive care that we're going to look at in this study is obviously the management of their diarrhea. So diarrhea has been said that it's is present in children, but it's of trivial consequence. But actually, when we found in this observational study that actually it was present in 49% of children at admission, and another 15% of children developed diarrhea during admission. The in-hospital case fatality for those who had diarrhea was 21%. And if you actually had signs of severe dehydration, that mortality went up to substantially higher of 39%. These listed on the bottom are all the key independent risk factors for death: altered consciousness, severe electrolyte depletions, the presence of shock, and gram-negative bacteremia. So I'm just going to simplify what the current guidelines are for the 2 groups. I'm sure everybody who's on this call are very, very familiar with it, so I'm not going to do these in detail. For the non-malnourished children, we have Plan C for this severe dehydration that includes initial shock management for those who are in shock, and then rehydration, 100 mils per kilo, which is given over 2 phases. So 100 mils per kilo has been estimated is what is required for those who have severe dehydration. In other words, they're 10% dehydrated. So for those who have moderate or some dehydration, they just go straight on to oral rehydration. Obviously for those who are following oral shock management, they all go on to oral rehydration. That's very, very different management from children who have SAM. It recommends that the children should only receive a low sodium oral rehydration solution, and fluids should only be reserved in the case of shock. These are the two sachets, just to show that the sodium content is very different. These are the current WHO ORS, and this is the sodium content of ReSamal. This is the very original guidelines. It said that children with signs of severe dehydration but not shock should not be rehydrated with IV fluids. It has been very strongly taught that the signs of dehydration are difficult and often misdiagnosed. Given IV fluids puts children at risk of overhydration and death from heart failure. Therefore, they should only be rehydrated orally. So these are very, very strong statements, but were they based on evidence? No. So ReSamal should only be used after dehydration is carefully assessed and based on medical history and clinical signs only in inpatient facilities under strict medical supervision. They suggest that this medical supervision should be every 30 minutes while receiving ReSamal for 6 hours. and that it should be stopped if any of these signs appear. So again, raising the concern that even with oral rehydration, you can put children into a fluid overload. So these guidelines, the original ones were released in 1999, and the more recent updates where there has been no change in the guidelines. This is despite that actually we have looked at, I mean, one of the strong recommendations is that children's myocardial function is impaired, that their heart is weak, it's small, and it does not respond well to fluids. But actually, we have looked in a very, very detailed study in myocardial function in children with severe malnutrition who did receive fluid. And this is not just the work that we did, but also work that was done supervised by Liz Molyneux in Malawi. So in total, over 250 children have had their myocardial function studied. And what we found is that they have a very, very high systemic vascular resistance when you come in. That means that they're very, very volume contracted. So the children, but when they receive fluid or fluid resuscitation, actually that improves over time. A measure of their heart function is called stroke volume index. And what you do is you see that improve over time with fluids, not fall apart. And all of these are what's called Frank-Starling curves. All of those go in a positive direction, meaning that these children have a positive response to fluid resuscitation or rehydration and not a negative one. So that brings us to say that, well, this is now, there is a cause for equipoise. We've demonstrated that the concern of impaired myocardial function, stopping you giving rehydration, intravenous rehydration, we've not been able to show that, whereas guidelines continue to recommend very, very conservative oral only, but only use as fluids and cautiously in the evidence of shock. So this underpins the rationale for doing a clinical trial. I'm going to hand on to Lizzie to take the next slides.
Many thanks, Kath, and it's a pleasure to be here today to talk about this trial. So Kath's given a bit of the background, so I want to start with the trial hypotheses, the kind of research questions that we directly wanted to answer with this trial. And for children with severe acute malnutrition and severe dehydration, we hypothesized that compared to the oral rehydration only, which was going to be our control arm, the current standard of care, we were hypothesizing that a standard IV regimen for non-SAM children, which is also called Plan C, would result in better outcomes. So we felt that would be better. And in addition, we hypothesized that 100 mils per kilogram given over 8 hours in these children would also result in fewer fluid-related adverse effects than the WHO Plan C guideline. Was also more straightforward because the this kind of Plan C has different rates for different ages and over different times. We also wanted to consider children that had some or severe dehydration, and in that group we hypothesized that a standard ORS solution may be equally as effective with fewer side effects than the low sodium ReSOMAM. Next slide, please. So with those trial hypotheses and with the design in mind, we developed a multi-center investigator-led individually randomized controlled trial, and it was registered on ISRCTN, and the number is there. And the protocol was published in Wellcome Open, and the SAT was publicly available. So we set it all up, and it was funded by the UK NYC Joint Global Health Trials Scheme, and MSF came in on board as a collaborator and funder, with the trial being sponsored by Imperial College London. Next slide, please. So I'm going to just first start by describing the comparison and the trial design for those with severe dehydration. So next slide, please, Kath. So in those children in particular, we randomized them through 2 to 1 to 1. So that's double the amount of children in one arm, in the control arm, and standard of care. And in that arm, it was going to be that if there was shock, then they would receive a bolus as described on the slide, but then they would have no further IV rehydration, and it would just be oral rehydration given through a nasogastric tube if needed. The other two arms that we were randomizing to, we referred to as more liberal because they were using this IV rehydration strategy. For the middle arm on the diagram, we had what we called liberal rapid, which was similar to the WHO Plan C as we described, and there was a bolus given if there was shock. Otherwise, there was a rehydration strategy given in different steps and slightly different amounts over dependent on the age, which was Ringer's lactate. And then we also wanted to look at a liberal slow strategy. So this was 100 milliliters per kilogram over 8 hours. And that group also, if they were in shock, they didn't receive a bolus. They were just started immediately on the slow IV rehydration. Thanks, Kath. Next slide. So to get a sense of the trial design, in addition, that was how we were going to randomize children, but screening for this trial took place simply as children were triaged on presentation to hospital. Our consent process went through the appropriate ethics committees, and we did have a deferred parental consent, so the most sick children had a verbal consent process before a formal written one. And clinical monitoring did take place very regularly. So these children were monitored every 30 minutes for the first 2 hours, then hourly to 8 hours, then at 12 hours, and then every 12 hours thereafter while they were admitted in the hospital. And the doctors and clinical staff were very actively soliciting signs of fluid overload at each one of these reviews. As mentioned before, if children were unable to tolerate oral fluids and were randomized to the arm that received those, then nasogastric tubes were used. And all the data from baseline and screening and assessments, then through this clinical monitoring and bedside observations, all the fluids received and the outcomes and adverse events were recorded on case report forms and then entered into the database. And we had oversight from an independent data monitoring committee and a trial steering committee with independent members. So they checked in on how the trial was progressing, and the IDMC could see the data as the trial went along as well. So we were really interested in seeing improvement and comparing these different arms on our primary outcome, which was mortality at 96 hours, which is obviously critically important. We were also very interested in following up these children to 28 days and looking at their vital status at that point. We also looked at the change in weight and mid-upper arm circumference at day 3 and at day 7. Safety endpoints were critical in this trial, and we were monitoring very closely for all of these. So these were evidence of pulmonary edema or heart failure, development of shock, neurological deterioration, and we also wanted to consider change in the sodium at 24 hours post their IV and the correction of electrolyte abnormalities. Our primary comparison, and you'll see these in the results table, is looking at those liberal strategies joined together, the two liberal strategies versus the control, or as we kind of consider the oral strategy. And that's because that's really what we were expecting to see a difference for our primary outcome, and we had more numbers if we compared them this way. So that's why we've done that. So our randomization was done with a permuted block and stratified by site, and was very successfully implemented using sealed opaque envelopes at all of our sites. The adherence was excellent in this trial, and both adherence and retention really were very good, and is a testament to the team's hard work in ensuring that we had the highest data quality and adherence to the protocol. So all the children that needed boluses that were in shock did receive them, and then the fluid management, as outlined in the protocol for each arm, followed it very closely, and we were really pleased to see that. And For retention, we had a greater than 99% follow-up for our primary outcome at 96 hours, which is excellent. But then even then, 98% follow-up for 28 days. So the teams really worked very hard to make sure participants could come back, or that they went out to find them. And we also had, I'd say, really good completeness for our biochemistry sample results during admission and then at 28 days. So you can see in the flow diagram, we enrolled 272 children into this part of the trial. We had 138 in the control, 67 in our liberal rapid arm, and 67 in our liberal slow arm. So it's 134 for the comparison against the 138 in our control arm. So that was what we hypothesized, and that's how we designed our trial, and that's how we wrote our protocol, and it all came together. So now I'm going to pass over to Dr. Ouattara to talk us through what it was like to actually kind of implement this trial on the ground. So thank you, Dr. Ouattara.
Okay, thank you. Hello, everyone again. Sorry, I will stop my camera to optimize the network. This is just to give you an overview of the study practicalities and my personal reflection on some of the challenges that we face during the implementation of this trial. So 6 sites in 4 countries were involved in the recruitment of participants in this study. We had 2 sites in Uganda, Soroti and Mbale, and 2 sites in Kenya, Kilifi and Coast. The East African and Central African site were urban area, stable context. These sites have really well-structured research institutions, and they receive quite a lot of patients who has malnutrition in the years. We also have 2 sites in West Africa, relatively close geographically. We have 1 site in Magaria in Niger, and 1 site in Maiduguri in Nigeria. Those sites in West Africa are located in rural area, unstable and humanitarian context. They all have MSF nutritional centers based in the MOH, and they receive huge number of malnutrition cases during the years. These different contexts will certainly lead to different challenges that are faced by the sites. These are some photos that I've collected to give you a real view of the sites. You have on top right the MCRI in Uganda and the nice building of Kemri in Kenya. Down you have the site of Maiduguri and a photo of Magaria taken between the extension tent during the peak season, and on top left you have the hospitalization wards. The site of Uganda and Kenya have started the recruitment in 2020, and they were really impacted by the COVID-19 pandemic with the different restrictions. And after also, as I mentioned earlier, these sites are based in a really stable context, non-humanitarian, and they were facing lack of many eligible cases. You can see on the graph here that the COVID-19 restriction has really impacted the recruitment in the site of Mbale, Kilifi, and also the Ugandan site. And when the MSF site joined the trial in end of 2023, we can see how the recruitment started picking up. In Niger, we mostly faced logistic challenges. You remember in 2023, we have had a military coup in the country, which led to movement and import restriction in the country. And so the sport chem, which is a lab equipment to test electrolyte, arrived in the site. And so we were able to store the sample and test them later. We also had some of the tests that were not available on site, like the full blood count, malaria blood film, and blood culture. Yes, Nigeria. In Nigeria, the flood in September 2024 was really memorable. It has really affected the recruitment. You can see how the houses are in water. They also experienced some equipment breakdown, notably ISTAT, which is an equipment to test the electrolyte. which has also altered the recruitment for a moment. Due to security issues, they have difficulty following up with patients coming from red zone or who do not also have access to phones. This is a quite common challenge, I think, to all the sites. Conducting clinical trial on life-saving treatment in really critically ill patient like Kathryn mentioned earlier could be really challenging. We have to follow carefully the protocol and the study procedures while being able to deliver the treatment on time. And it was essential for us to have a well-trained and very experienced team to be able to deliver the treatment to minimize the delay in giving the treatment to these children. This is a case story of a child of 9-month-old who was admitted for gastroenteritis complicated by severe dehydration and hypovolemic shock in the site of Niger. He was eligible for the study and was randomized to GastroSAM slow arm that Lizzie presented. This is 100 milliliter per kg for 8 hours in slow perfusion. So this child was started on lactate 480 milliliter for 8 hours. And when we do the calculation, he was receiving 1 milliliter per minute. So this led to really a big discussion within the team because this is really an unusual way of treating a shock. Some of the time we have this kind of discussion when we face treatment contrast between the usual protocol and the GastroSAM protocol. We usually have this kind of discussion. After 1 hour and a half of lactate infusion, the shock was resolved for this child. After the 8 hours, he was well rehydrated, but unfortunately, 1 day after hospitalization, the poor boy unfortunately died on the account of an associated sepsis also that was diagnosed. This story just to say that we are in a context where there were no evidence-based validated protocol, and there are this kind of genuine discussion between the team on whether what is the best treatment arm. But we always strictly follow the protocol, as we know that this was essential to ensuring scientific validity and participant safety, as well as to guarantee unbiased result. Yes, just some key elements that have contributed to have this high quality implementation of the study. The first one being the excellent trial management that we have had with regular meeting and monitoring of study progress, and the trial management group was also able to provide timely support to teams on field because the trial was really challenging. We also had on-site adequate GCP monitoring that helped to ensure that the protocol and the SOPs was very well followed. We will not stop saying it. We had a well-trained and very experienced staff during all the trial in all the site. We know that this has also contributed to have a good implementation trial. The 4 clinical trial excellence was also observed during the study. As Lizzie mentioned, you can see that we have had a good performance in retention and completeness of the data. The data team also supported very well the trial. I think this is my last slide, just to say thank you to the teams. You have the team of Magaria and Maiduguri here. Apologize to the team of Kenya and Uganda that also deserve to be here on this slide. Thank you. Yeah.
Thank you very much. That was a lovely presentation and really brought people to the sort of realities of trying to conduct a trial. You know, a lot of people always say, how do you do these things? But it takes dedication from the entire team, and you have really demonstrated that. So I'm going to move on to presenting the results now. So as Lizzie had said, that we're going to compare the control to the pooled liberal strategies, the rapid one, which is Plan C, versus the slow IV rehydration. So overall, a lot of the children in the trial, there was for all of the actual baseline, there was balance, a good balance between the two randomization arms, meaning that there was no bias. So they were quite young. The median age of children was between 12 and 14 months. They were obviously, as you can see, very, very severely malnourished, although we didn't have a very high number of children who had the kwashiorkor phenotype. I've highlighted previous admission for malnutrition, even although these are very young children, they already, quite a number of them have already been admitted for malnutrition previously. This is a risk factor for a poor outcome. As you can see, most of the children were unable to take or retain oral fluids, and they had a very low appetite. Altered consciousness and also signs of shock. Altered consciousness was present in quite a high number, and WHO signs of shock, which requires all three features, was present in around about 10%. So again, those are highlighted because they are independent risk factors for fatal outcome. So what I'm trying to present is saying that these children were very sick when they came in. And their laboratory measures absolutely said that. Half of children had very, very low potassiums, a severe hyponatremia, and a potassium below 125. And between 40 and 50% had severe hypokalemia, again highlighted because these are key risk factors for early mortality. Overall, we didn't see very few had malaria, but quite a number of children had positive blood cultures, and a lot of these blood cultures were gram-negative organisms, again risk factors for fatal outcome. So how do we manage these children? How do we get on with the management of these children? I'm going to go to the control arm to start with. So although that they were meant to be receiving oral rehydration, we've written down the time to start IV fluids. Most of these were because the children were started in shock or developed shock during management. So overall, 22% of children in the control arm, not all were in shock to begin with, required IV fluids. So that is quite a high number. If we go right down to the bottom, where we've got nasogastric tube insertion, you see 93% of children required NG tube. This is largely for their rehydration, and you had a high number of reporting vomiting. If we go to the pooled liberal, you see that we've obviously all of them, apart from one, I think one child, because the child died before they started, fluids could be started 14 minutes from randomization to starting IV fluid. So you see that these were managed very, very rapidly. If we look at the pooled, if we look at the rapid group, those who received, eight children were in shock, and 7 out of 8 received a bolus. It was one child that didn't, because they died before they could receive that. In the slow arm, we as per protocol, again, we started IV fluids early, but we didn't give any bolus, even to the 5 children who were presented in shock. If we come down to we'll go back to the pooled liberal, because it's similar for both. That actually the frequency of IG and nasogastric insertion and also vomiting was significantly lower in the pooled liberal group. So these are our outcomes. So overall, we saw no difference in mortality. There was an 8% mortality in the control, and that was versus 7% in the pooled liberal, with a slight difference in between rapid and slow rehydration. But this is mortality in 96 hours. This is very, very low mortality, and it was not because the children were not sick. We then looked at mortality at 28 days, 12% in the oral group versus 10% in the pooled liberal, with a slight difference between the rapid and the slow. But again, these were not statistically significant. Children who, for those who were able to monitor a urinary output, of course, children receiving liberal fluids had a much higher urinary output at 8 hours. And we saw really no difference in weight gain at day 3. So this trial was about safety as much as it was about trying to save lives. And if you see in both the control arm and the pooled liberal arm, we had no evidence of pulmonary edema or evidence of suspected heart failure. And this was not because we didn't look for it, because every time that the doctors went to the bedside, they had to try and look to see whether the child was in overload. We had a number of other outcomes that were of interest to us. Obviously, the presence of severe hyponatremia, early hyponatremia, predicts mortality. We saw that was much, much more frequent at 8 hours in the control arm versus the pool arm. But by the presence of severe hyponatremia, given that even although the pooled arm had obviously substantially more sodium-rich fluids, we saw no difference in those developing severe hyponatremia, in other words, developing sodium overload. There was a difference in the number receiving with severe hyponatremia at 8 hours, largely because the ORS in the control arm, they were receiving ORS earlier than those in the pooled liberal. So overall, the control group had many more serious adverse events, 23% versus 18%, and there was some difference between those in the rapid arm versus the slow arm. Development of shock was higher in the control arm, but this was not statistically significant. And we were also concerned about neurological events. We didn't see many of these. Since this, and since we had this result, we conducted we assembled all the available evidence and did a systematic review and meta-analysis. So unfortunately, there has been only 3 studies. One was conducted in Kenya, one was conducted in Bangladesh, and one was added to this was the GastroSAM trial. And the first figure at the top left-hand corner is this in-hospital mortality. So the ALAM trial, they had no mortality. If the diamond is, you see the diamond at the bottom, if the diamond is to the left of the line, that means to say that mortality is lower in the treatment arm versus the control. But obviously the diamond touches that black line going down, so it's, and showing that with the confidence interval that overall that it wasn't statistically different. But what we can say from when we look at this, that the giving IV rehydration compared to oral rehydration ranges from a 54% relative reduction to a 10% relative increase in the risk of death. We were able to assemble all the data on fluid overloads, and that's right in the middle, because for every single study that's looked at this, or the controlled trials that looked at this, we found 0, 0, 0. 0, 0, 0. So the emerging data suggests that actually children receiving IV fluids is not harmful. So in conclusion, we saw no evidence of a difference in mortality at 96 hours, our primary outcome, nor at 28 days. We had a substantially lower mortality than expected because we wanted to run the trial to a very high standard. We had an increased level of staffing that provided a good bundle of care, close bedside monitoring during the first 4 days. And as I say, the bundle of care was given across all children and not just specific children. So they had a very high level of care. The close bedside monitoring is actually slightly less than what is recommended for just Risomal for children. So they say every 6 hours for the first day. So sorry, every 30 minutes for the first 6 hours, whereas we did every 30 minutes for the first 2 hours. I think the most important conclusion we found that there was no evidence that giving IV fluids or even giving oral fluids resulted in fluid overload. We felt that the IV strategies were simpler to implement than the especially slow rehydration, because you could just give one rate without having to worry about treatment of shock. The ORS strategy only resulted in an unanticipated very high number of children needing nasogastric tubes for rehydration and 22% requiring fluid boluses for shock. So we think that they've simplifying fluid strategies across malnourished and non-malnourished should be the future. Thank you. And I just wanted to highlight that that has been published. You can scan the QR code for that. And I was going to thank everybody, but I think everybody's going to be thanked right at the end. Thank you. Back to Joanne.
Thanks so much, Kath and team, for that amazing presentation. So what do we do from here, I guess, is the question, and that's why we invite Roberta to come and discuss some of the trial implications. What does that mean for us, and what does that mean for global guidance on this topic? Roberta.
Thank you very much, Johanna. Thank you to Kathryn, Lizzie, and Ouattara for the great presentation. Especially thank you for the teams on the field that did this incredible work in such challenging conditions to bring us those results today. And there are a few questions we might ask ourselves about the result of the GastroSAM studies, and try to see what are the potential operational implications of the study. And the main question is going to be, can these results help us rethinking the current protocols? So what are we learning today? I think one of the main results is that actually using IV rehydration in SAM is safe, even among those that were receiving a fast regimen on Plan C with big amount of fluids, quite fast. There were no cases of fluid overload. And this is consistent, as Kathryn explained, with previous studies that did not report episodes of fluid overload, and also that reported that actually cardiac function is similar between children with and without malnutrition. This body of evidence is not just the GastroSAM. Again, it's several studies challenges the assumptions that children with severe acute malnutrition are at high risk of fluid overload. This assumption has been described as a dogma in some New England editorial because it's so difficult to challenge, and it's based on no evidence. This is what we have been taught since our studies in medicine, what is written in the clinical guideline, and also one of the main points that were reported in our Mentimeter, one of the main concerns. But again, there is no evidence that support this statement, and there is growing body of evidence challenging it. There is another important finding of the study. It's quite an indirect one, but I think it's still important. And that is that mortality was much lower in this study than what we expected based on literature. Why is that? I mean, it has been explained a little bit. It's probably related to the study environment itself. In the trial setting, the teams are very well trained. They are dedicated to following up the patients. We couldn't do otherwise. I mean, it would have been unethical to run a trial with suboptimal care. But this observation, even if it leads to some limitation in the results, suggests a very important point. It's just that mortality might be at least partly related to a gap between the workload and the workforce. In many nutritional units, in most nutritional units, and also in many African pediatric units, the reality is that wards are usually overcrowded with many severely ill children and with limited staffing. The frontline workers usually do not have enough time to do proper follow-up, monitoring, adjust the treatment. They also don't have, often they don't have proper access to proper training. And it's very difficult to navigate complex protocol and to provide individualized care. Of course, we would like to see more human resources, more training, and more capacity to care for these patients, but we also know that it's unlikely to happen soon. So if we cannot increase the number of doctors and nurses that are taking care of these children, there is another question we could ask ourselves. Can we give more time back and better tools to the frontline workers by simplifying the protocols? today, when I'm at the bedside of the patient, before deciding what I'm going to prescribe as a rehydration regimen, I have to take into consideration many variables: the nutritional status of the child, the age of the child, the weight, the degree of dehydration, and then I have to prescribe the route of administration that changes according to the previous parameter, the fluid type, the infusion rate, and this needs to be adjusted because the amount of fluids changes over time. And this is not just once. This is steps that have to be performed with each single patient. And we said there are many patients that are under this condition. So this complex decision-making algorithm is time-consuming and can easily translate in delays and errors. So what if we could define one simple protocol independent of the nutritional status that requires less calculation and less adjustment? Of course, if the child can drink, oral rehydration should be the first choice. There's no doubt about that in children with some dehydration. But the GastroSAM study shows that in a child with severe dehydration, when the oral rehydration is not possible, then IV rehydration is safe and can be used wherever is feasible and regardless of the nutritional status of the child. When it comes to the amount of fluids used through the IV line, the current practice is also based on very little evidence. We usually use Plan C, as Kathryn described, for non-malnourished children, and basically only a bolus for malnourished children with shock. But again, no strong evidence supporting this approach. And we hypothesized actually that a rapid correction might not fully consider the pathophysiology of rehydration. Rehydration is not just simply about restoring fluid volume. It also involves correcting electrolyte imbalances, restoring perfusion, support organ function, including kidneys, brain, heart. So these physiological adjustments are often better achieved gradually rather than rapidly. So this is why we try to explore in the GastroSAM study the concept of a slower rehydration protocol, delivering the same total amount, so the 100 milliliter per kg, but over a longer period, with two positive results. One, we correct slower all the imbalances, but it's also easier. It's one prescription, one calculation over time that we don't change over time. And the results of the study support this simplification, suggesting that this approach is safe. And this will help simplifying protocols. So now the next question is, and this is a question that we ask ourselves several times, does the GastroSAM study provide enough evidence to change the current recommendations? And we fully acknowledge the limitation of the study. It has been mentioned several times. But perhaps there is a more important question, that is, how much evidence do we need to change recommendations that are originally based on no evidence? This is an incredibly hard study to run, and it's very unlikely that a much larger trial will be done in the near future. And we have seen this before. For example, when the FIST study came out in 2011, if I'm not wrong, showing, as Kathryn mentioned, an increase in mortality in African children with septic shock receiving bolus, the evidence at the time was considered insufficient because it was only one study, despite the large number of the patients involved. And it took nearly 10, 15 years to realize that no other evidence was going to be produced and that the findings actually could eventually influence the clinical practice. So 15 years that we missed the opportunity to provide better care. It's happening a bit the same with the TRACT trial, but I don't want to get off road. But the idea is like, let's assume, for example, that no larger study will be conducted about this specific population, the population understanding the GastroSAM in the near future. What should we do? Should we continue to rely indefinitely on recommendations that are 30 years old and based on no evidence? Can we keep doing the same thing, knowing that we are facing a reversible condition because dehydration is reversible, and still we have a very high mortality? Or maybe we could think that current evidence is sufficient at least to reopen the discussion. And again, the discussion is not only based on the GastroSAM. There is a growing body of evidence that support the same result, support the safety of this approach. There might be another question. And the question could be, maybe promoting IV fluids in the real world, under real world conditions, so outside of a study setup, may result in a much higher risk of adverse event in contexts where we already mentioned that there is lack of enough and qualified frontline workers, lack of ability to manage IV lines, lack of infusion control device that could potentially lead to increased mortality. And yes, of course, poor quality of care as an impact of mortality, this we know, but this issue applies regardless of the child's nutritional state. If we assume that there is no major difference in cardiac function, there is no high risk of fluid overload in nutrition in malnourished children, then this point doesn't justify two completely different protocols for children with and without SAM. And in fact, this argument goes in the same sense that simplifying protocols is especially important in this kind of context and can contribute per se to save lives. So one might wonder, should we stop recommending IV fluids altogether in settings where these conditions are not ideal? Well, this could be considered if we had a better option. And again, oral rehydration is safer. Go for it whenever it's possible. But when oral is not possible, then we might ask a next question. Is nasogastric tube easier to manage and safer than IV line? In general, there is little evidence about this. There's little evidence comparing the two, rehydration via nasogastric tube and via IV line. But in practice, nasogastric tubes require skills and time. Staff must check that the tube is correctly placed, monitor it, ensure it remains safe throughout the fluid administration. And if not performing properly, serious complication can occur. Things can go very wrong. And in reality, inserting and maintaining a nasogastric tube is not a simple procedure, and it's not necessarily less time consuming than an IV line. There is often one reason why nasogastric tubes are perceived as easier, and that's because mothers are frequently asked to manage them. I wish we were in a room all together and I could ask you how many of you have seen mothers managing rehydration through a nasogastric tube. I suspect there would be many hands up, and some of those hands will remain up even if I was asking if the seen mothers actually inserting the nasogastric tube. So is it really safer? There is another important operational reason to change the recommendation, and it's that it's already happening. Frontline workers are already giving some kind of IV fluids in some children with severe dehydration. You remember the Mentimeter we did at the beginning? 60% of the people around the screen said they do somehow IV, usually mixed with oral, but some IV is given. And this is also my personal experience. In 20 years, I've been working in this kind of context. Most of the time, probably all the time, I've seen clinicians giving some IV fluids to this kind of children. And I can tell you, it's very uncomfortable to have a child with severe dehydration, severely malnourished, and just use the oral rehydration. So I totally understand. But the problem is that we give fluids, IV fluids, in a non-standardized way. So according to our personal feelings, because there is no recommendation around that. And in medicine, usually it's really a good idea, to go according to your feeling. So recommendations are strongly needed to support a practice that is already happening in reality. So we believe that the findings of this study can help guide a discussion and trying to redefine the rehydration protocols with the main goal of simplifying them. And there is ground for that. So this GastroSAM study supports a paradigm shift between, based on these findings, that, as we said, intravenous rehydration can be used safely in children with severe acute malnutrition, that separate protocols between SAM and non-SAM children might not be necessary anymore. We also believe that a slower rehydration is a simple and physiologically sound option. And most importantly, simple protocol could save time for frontline workers, and that rather spending a lot of time doing complex calculation, counting the drops, they could actually spend time examining the children, identifying underlying causes, monitoring them, adjusting the treatment. In this context, actually, less might indeed be more. And I would say also that in our case, less and slower might be more. So thank you very much. Back to you, Johanna.
Thank you, Roberta, for this articulate summary and giving us some pause for thought. So thank you for those who have posted some questions in the chat. In the interest of time, we're going to group the questions at the end. So we're going to continue with now GastroSAM B and discussion of the oral rehydration strategies. Please continue to post your questions in the chat. We will get to as many as we can. If you like a question that's been posted, you can also upvote using the arrow, and that way we will see which is the most popular and can try and make sure they're addressed. I'll ask Kath to reshare the screen. We stopped sharing while Roberta was talking. So I'll invite Kath back to reshare, and then Lizzie is going to discuss the trial design for GastroSAM B.
Oh, this is the right one. Yes, well done, Lizzie.
Yeah, no worries at all. That's fine. So now we're thinking about the oral rehydration solution comparison, and that's where we brought in children with some dehydration and included those that we've already discussed with severe dehydration. So you saw this trial schema before, and basically I've just extended it sideways, and you've got these children with some dehydration, and that was an additional 143 plus the 272 with severe dehydration. And they were all randomized, just 1-to-1. So either Resomal or WHO ORS to be used whenever their oral rehydration solution needed to be given. So next slide, please. So for this comparison, we were very interested in understanding if it changed the sodium level. So they're looking at the change in sodium level at 24 hours from baseline and comparing that between the two different solutions. Our secondary outcomes were considering a change in sodium levels at 8 hours, also thinking about our long-term clinical outcomes, looking at mortality to day 28, and then also considering a change in weight and MUAC at day 3 and day 7. And we were also had the same safety endpoints for this comparison. So we were very carefully keeping an eye out and looking for evidence of pulmonary edema or heart failure in these children, and thinking about, especially with comparing the different solutions, correction of electrolyte abnormalities, looking at those who had severe hyponatremia or hypokalemia during the follow-up. So as before, our randomization used permuted block randomization stratified by site and then the strata. So A is those with severe dehydration and B is those with some dehydration. And we were bringing them all together for this comparison. And again, it was successfully implemented for this bigger group of children that we're now talking about. Adherence for this larger group was also really good. So 98% in the Resomal arm and 99% in the ORS arm received their allocated ORS, which was great. And just some of the few that didn't, some of those were mostly because they died before they were able to start it. And I think, and there's a bit more details later about the management, but we were, again, the teams worked really hard and they followed the protocol very closely with regards to the amount and rate given for each different oral rehydration solution. And the retention for this bigger group of children in this comparison was really good, and we had 98% follow-up for their vital status at 28 days. And we had 93% completeness for the biochemistry sample results, which were what we were going to use for our primary outcome, particularly looking at sodium. Next slide, please, Kath. Thank you. So this is just the trial flow. Just to highlight again, we've got these two different groups that came together to be allocated either to Resomal, 206 to Resomal and 209 to the WHO ORS arm, and we were really pleased with the adherence. As you can see, very small numbers didn't receive what they should have done, and we had really high follow-up and completeness of data for the primary endpoint there in the bottom boxes. So thanks very much, Kath. I think that's my last slide. So I'm going to hand back to Kath now to talk through the results of this comparison. Thanks, Kath.
Thank you. We'll go straight to the baselines. as you saw, 206 versus 209. The first column is the RESAMAL column, and the second one is the children who in the ORS. Again, we've got good balance between the two arms, meaning this, the randomization hasn't introduced any biases. I think overall, altered consciousness, again, a quarter of the children had altered consciousness. Obviously, a lot of them had sunken eyes and abdominal skin pinch, multiple signs of dehydration. Half of the children were unable to take or retain oral fluids. Even although this randomization did include obviously children coming in from the GastroSAM, so of course some had shock, and that was managed according to what they were randomized to in the first place. So even although we have this included a slightly the less sick group of children, overall the actual mean sodium level was 125 in one arm and 126. So again, they were pretty sick. The proportion who had severe hyponatremia was 40% and 44%. Potassium was low in both arms, with a proportion with severe hypokalemia, approximately 40%. And as we reported before, very few children had HIV in the trial. And again, the blood culture positivity reflects just those who came in from GastroSAM A, but also a number of other children in the some to moderate malnutrition actually had a positive blood culture as well. So we had very good adherence to the actual interventions that we were due to follow. So no child who was randomized to RESAMAL received ORS and vice versa. So there was very good adherence before, and the total volumes reflected what the current recommendations were. If we look down, we found that overall 72% and 74% required a nasogastric tube at all, a lot higher number in the strata, GastroSAM A strata, and that's largely because 50% of those children, the children in that strata, were randomized to ORS, to the control arm, reflecting the very high NG tube requirement in that group, with a slightly less children in the second strata, but still 60% requiring nasogastric tube. Relatively few children required corrections for hypoglycemia, slightly different between the RESAMAL and the ORS, but that was not statistically significant. So if we just to remind that the primary outcome was a sodium change at 24 hours. We had obviously there's some children who did not survive to 24 hours, so that these are the summary, so that they didn't contribute to this, but overall we had a complete data on all of the children who did survive to 24 hours. And we showed that really there was the increase in sodium was no different between the RESAMAL arm and the ORS arm. Again, this was a concern that these children, that if you give them sodium-rich fluids, you're going to be giving them far too much sodium. Mortality outcomes to day 28, we saw slightly higher mortality at day 28, 12% in the RESAMAL arm versus 9% in the ORS, but this was not statistically significant. Again, we were looking, even in the children with some malnutrition, some dehydration, that we still didn't find in those children receiving ORS any evidence of pulmonary edema or heart failure. So what we did see a difference in is at 8 hours, and again this is a critical time point where in early management having a high frequency of severe or a persistent severe hyponatremia is a risk factor for poor outcome. We saw that was statistically higher in those who had RESAMAL compared to ORS, 32% versus 22%. The development of severe hyponatremia at 8 hours was slightly higher in the rehydration arm, 3% versus 1%, but this was not quite significant. But again, that concern that giving high or sodium-rich solutions would result in a lot more hyponatremia was not realised in this study. There was no difference in the rates of severe hypokalemia at 8 hours. At 24 hours, there was no real large differences, although you still saw that the severe hyponatremia was still persistent in both arms at 24 hours in 20% of children. If we go down to the potassium change, it was slightly greater. 0.5 versus 0.3 in the rehydration arm versus the ORS arm, but it's sort of clinically a 0.2 difference is really not a sort of clinically significant change, given the fact that a lot of them have very low potassiums overall. And by day 7, quite a lot of those electrolyte perturbations have resolved in many. So we didn't have any persistence in hyponatremia. But again, that was slightly higher in the rehydration arms compared to the control arms, with a p-value of 0.05. So in summary, we found similar results to the rehydration, but neither strategy led to a fluid overload. Severe hyponatremia was statistically greater in children receiving severe rehydration at 8 hours. We had directly addressed one of the research gaps that have been identified, looking at the safety of using standard ORS in children with rehydration, and we have found it to be safe with fewer adverse events. So I think we consider that that actually this component of the GastroSAM RCT supports the simplification of guidelines using the ORS for the management of oral rehydration, regardless of nutritional status. At the moment, the guidelines say you must not give ORS in the community because it's too dangerous to give. You should be giving them rehydration or ORS if that's only what's available, but it must be given in an inpatient facility. Maybe if more children were able to receive rehydration solutions in the community, that might reduce the requirement for admission and also reduce overall mortality. We're a little bit concerned overall. This is a study that was done by one of my colleagues, Jay Barclay, who showed that actually when they re-looked at children who were undernourished but not severely malnourished at discharge, who'd come in who were dehydrated, they found that up to 20%, once they were properly rehydrated, had been misclassified as severe malnutrition. So putting that strict sort of cut off, saying, if you're below a certain weight, or you have this is including MUAC, if it's below a certain, you have a completely separate management criteria. So this has slippage. So it extends to undernourished children who could have been managed by other guidelines. So again, as Roberta talked very passionately, we think that simplification is required. I just want to acknowledge all of obviously the clinical teams, and as you saw how well they did the study, the MSF operational teams from within the country and across Europe coordinated all the logistics, and this was not easy, and we really, really appreciate that. As you see, that we had very, very numerous challenges, but we got to the end eventually. And I just also wanted to thank our independent steering committees and data monitoring committees that kept this trial, ensuring that the integrity of the trial, and feeding back to our funders, who at some stage wondered whether we would ever get to the end, but we did, and we've got 2 fantastic results. Thank you very much. Joanne, you're muted.
It's better if I turn my microphone on. Thanks so much, Kath and team. And I'll hand over again to Roberta to discuss the policy and practice implications for the GastroSAM B oral rehydration arm. Thanks, Roberta.
Thanks, Johanna. I'll keep it short because Kathryn gave a very exhaustive explanation, so there is little to add. And I think it's also important to leave space and time for questions. So I really encourage everybody to ask your questions in the Q&R part, and we will dedicate the last part of the webinar to try to answer those questions. So going back to GastroSAM B and oral rehydration, I think the key learning point is that low osmolarity WHO standard ORS is safe in this population. And this leads to, I think, the key point in this part of the discussion. Should we consider starting oral rehydration in these children in the community level? Because today this is not recommended, this is not possible. So out of the same concern of fluid overload and sodium overload, Resomal and oral rehydration should be done under medical supervision. That's what the current recommendations are. And again, these recommendations are not supported by evidence. And I think this study provides new element to try to correct it. It's a practical implication. Today, Resomal is not even available in the field because it comes in big sachet that could only be used in the hospital, while ORS is normally widely available in the community. The mother of a child with some or moderate dehydration can go home with the ORS. In practice, a child today with SAM and the gastroenteritis and a little bit of dehydration basically either go home with plain water or has to be referred to the hospital. And neither of these options is ideal at an early stage of gastroenteritis with some dehydration. And that's where we have the highest chance to save these children. So allowing community workers to use the standard ORS for these children with severe acute malnutrition at the very beginning of a gastroenteritis, when they still have known or mild dehydration, can really potentially have a big impact on reducing unnecessary hospitalization and eventually reducing mortality. So I think, again, these last findings of the GastroSAM encourage a simplification. So do we still need two different solutions and two different protocols for these two categories of children? You already know the answer because I've been talking about it quite a lot. But also this will help us starting treating these children earlier in the community. And that's it on my side, Johanna. Over to you to start with the questions.
Thank you so much, Roberta. And I'll invite our speakers to put their cameras on, so our 4 speakers. So thank you so much to all of our speakers, and we'll get to thanks at the end. But there are several questions in the chat, and no doubt there are many questions among many of you. So Kath, Lizzie, Ouattara, and Roberta. I'll go through some of the questions. Whatever we can't address in today's session, we just rest assured we will go and look through all of them, and we'll try to respond to each of them in some way through our Paediatric Days team. So first of all, Kath, if you're with us, I guess Feast taught us that less is more, but is this a case, is GastroSAM a case of more is more? So what do we take home from this? So if we're discussing the IV rehydration strategy, what do we take home? That there's no harm in IV rehydration, that it's equally efficacious, or should we be happy that oral rehydration remains the primary focus? What's the key message from you? I may have some connection issues. I might pass that one then to Roberta. What do you take home from this?
We've been discussing longly with Kathryn, so I hope I can represent her nicely. And yes, I mean, I've been discussing about it during operational implication. I think we feel confident that these results can actually be used, or can be used to at least start a discussion on whether we should change our protocols. If there is one take-home message, I think, from this GastroSAM study is that IV rehydration is safe. We didn't see any case of fluid overload, even in children that were receiving, big amount of fluids in short time, Plan C. It's the same again. We have been looking into all these previous studies that have been done with different methodology, different amount of fluids, and none of them reported fluid overload. So again, this fluid overload is an assumption that has little contact with the reality. So we think that this is strong enough to lead to a change in these protocols. The real question is like, is there a justification to keep these over complex protocols and decision-making protocols that are currently used? Is there a justification? Because if the justification, or the base of this justification is not there anymore, then we should really consider changing. And that's the discussion we want to trigger with this study.
And I think I saw some comments in the conversation of people welcoming and agreeing with some of your comments of the complexity of what that actually means when you're in these settings with huge numbers of patients, with minimal staff, minimal resources. So I think it's the feasibility is a huge point. I have some other questions that probably would be good if Kath was around, if we can just check she's still with us. But I will perhaps a practical point of view, maybe for Ouattara. I saw someone had asked how the IV fluids were given. Were they given by fluid pump or by dripper burette was one question. Maybe you can answer that from the practical side, Ouattara.
Yes, IV fluid was given by the fluid pump. So this was really well calibrated, and we had no challenges doing it. I know that the plan C is can be done even if you don't have this equipment. But the slow arm, in the slow arm, you need to have it to be very precise, especially for a trial. This is what I can answer. I don't know if you want to add anything on that one.
Thank you. But it's a real issue. We know that that fluid pumps aren't often available in some of these contexts, or not the numbers that we need. So the safety implications are important. There was a question that's been raised several times before, I know, of the low numbers of kwashiorkor patients, or the low numbers of children with edematous malnutrition. Perhaps, Roberta, you might comment on that.
Yes, that's of course an issue, because we know that these patients have other specificities, and the prevalence of kwashiorkor changes in different settings. In some settings, there is quite an important number of children presenting with kwash, and probably they deserve extra research. That's easy to say. We still don't know why these patients get kwashiorkor and some other get wasted, so it's very difficult to describe these patients. This said, I think that the few physiopathology studies about cardiac function also involve kwashiorkor patients, and again, there is no solid ground to say that they're totally different from the others in terms of how they react to fluids. But indeed, I would be a bit more cautious with these kind of patients. It's a shame we couldn't get more, but indeed, we work with what we had.
Okay, thanks. Another comment I've seen raised previously. I'm just checking. I'm just following up if we seem to have lost Kath, but it's okay. We've got the other three speakers. Another question that's been raised a few times is the difference in observed mortality from the predicted. I wonder if you could comment on that and the implications that might have had on the study findings.
Who's this for?
So I guess it's for you, Roberta, in the absence of Kath, and also, I mean, Lizzie might have some.
Lizzie might also want to comment.
Some input from the statistical point of view as well.
So I can start from a sort of statistical point of view, but then I'll hand over to Roberta. I think, yes, we had calculated a sample size expecting higher rates of mortality at 96 hours. And so it means I think it would have been very difficult to recruit a much larger trial. So we had the numbers that we have and the estimates that we sort of thought of in the beginning, and they were lower. But I think what we can take is all the other information that we have from the trial. So although we have quite wide confidence intervals around our estimate of effect, and that there's no evidence for a difference between the arms with the lower mortality rates, I think there's a lot more that we can take from this trial than just sort of only focusing on that kind of difference from what we expected. And I'll hand over to Roberta as a kind of next step from the kind of practical part of
yeah,
what
I mean,
means.
This was obviously a limitation of the study, but we can't say that we are sorry, of course, that we had such a low mortality. And I think that's a big success of our teams, because they were providing such wonderful care that, of course, they could really monitor in the evolution of the patients and treat accordingly. But this also proved that when the means are in place, mortality can be reduced. It's not, I mean, in terms of operational implication, it's a finding that's difficult to replicate again, because it's just not possible to have this quality of care everywhere. But we really believe that by simplifying the protocols, by simplifying the care, we could give more time to our colleagues on the front line. And this could somehow compensate for the huge amount of work. Again, I repeating myself, but we want less people doing calculation, less people counting the drops, and more people looking at the children and react and adjust the treatment. And especially thinking about the bundle of care that will decrease mortality. It's not just about rehydration. Rehydration is one component, but we have seen there are many other complications. These are complex patients. There is sepsis, there is electrolyte imbalance. There are several things that should be taken into account. And if we only focus on the rehydration, you miss many more. So I think that's the message that this low mortality is bringing with it.
Thanks, Roberta. There was also a question around, and I'm not sure if it was referring to GastroSAM A or GastroSAM B, around hypokalemia and potassium correction. So I'm trying to, there's quite a few questions to scroll through at the same time. So the observed hypokalemia correction is 40% in children. There's 40% of children having severe hypokalemia. How was this corrected?
I can answer that. Sorry, I'm back again. I got kicked out. My whole screen fell. No. I mean, we didn't give additional potassium. It was through the ORS. So we did not, because that's, I think, giving bolus or adding infusions of potassium is very dangerous. I think it can be corrected through the oral rehydration solutions.
Thank you, Kath. And can you also comment on the generalizability? So there were two different sites. East and West Africa are quite different contexts. Can you give some comment on the generalizability of the study findings?
Yes. Everybody will say, and I've seen it written in reviews of the GastroSAM, that actually we need another study, because this was because of the monitoring in this and blah 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 blah. But on the converse, if we hadn't done the monitoring, if we hadn't got confidence that children, we hadn't gone to the bedside and checked whether they'd got fluid overload, and we hadn't followed the protocol as well as we had done, then we'd have come up with a mess which actually wouldn't have moved the field forward. The reason why the GastroSAM trial was designed and run was because there was a concern over safety, and we found that there was no evidence of fluid overload. And I think that can be taken forward into general practice. This wasn't because children, yes, the rates of fluid that were given followed what the recommendations are, but 100 mils per kilo is 10%. Can anybody try and drink their 10% of their body weight in a couple of hours? Even if you're well, that's actually a phenomenal amount of fluid that is recommended. But actually, that was given IV, and which is a phenomenal amount of fluid. And actually, even even in that circumstance, we didn't see fluid overload. So moving forward, you know, it does mean that it's safe and we don't need to have all of these checks and balances, and children can be rehydrated rather like you rehydrate non-malnourished children. East and West, yes, there are differences. I think we have a lot of acute on chronic, where I think in the Sahel you have a malnutrition season, and it comes and goes. And I think there's possibly less chronicity, but I did note that there's about 20% of children had been in previously from an episode of severe malnutrition. And again, that is a risk factor for poor outcome. I think the bundle of care, irrespective of which arm you're in, that was delivered shows that actually A, being in a clinical trial improves outcomes. So, but also B, that we can do this with good quality care. I think that's hopefully.
Yeah, and it's a key message, isn't it? I mean, clinical trials improve clinical outcomes and decrease mortality is a key finding. There's a question posted in the chat about anemia as well, in the Q&A, about how that was managed with blood transfusions. Can you give a comment on that?
We didn't have a very high rate of anemia. Now, the definition of anemia is hemoglobin below 6, or profound anemia hemoglobin below 4. We would only standardly give a transfusion for hemoglobin below 4 or between 4 and 6 with severity features. We followed what was in the TRACT trial, that where we would give transfusions accordingly. I'm not quite sure how many transfusions were given, Lizzie, but I don't think it was that many. We've had lots of experience of fluid and management in the feast trial. We had a high proportion of children who had severe anemia, and they were successfully managed with control. So it's yeah.
And I think it's always a big question what you do in this situation when you've got a dehydrated, malnourished, anemic child in front of you. Do we rehydrate? And then
which one do you manage first?
Yeah,
I know.
Yeah. So I think, often it's not very clear.
I think the important thing is that in this trial and also in our transfusion trial, we did not use frusemide. So we didn't see fluid overload because we were using lots of frusemide. No child received any anti-failure therapy, and nor in the TRACT trial.
And I think this was a big question that came up in the chat at the start, and also some people have raised this in the chat and the Q&A about concerns of fluid overload and management with frusemide. There was also a question in the chat about whether any other indicators were used for fluid overload, or was it purely clinical signs? I'm just trying to scroll through and find the exact wording.
Yes, it was clinical signs. And as I think Roberta has said before, we all know how to look for evidence of fluid overload. They were listening to the lung bases. They were looking for evidence. And then
sorry, go ahead,
it was
Roberta.
the key point. So everybody was very much aware, and everybody was trained to look for signs, and it was constantly looked for.
Yeah, and as a follow-up question to that, were there concerns about reperfusion injury with rehydration?
Not quite sure what they mean by reperfusion injury. That's something that's a bit more specific to shock.
Exactly.
Okay, so I think they're the main questions. Sorry, there's a lot of things to scroll through. Feel free, please, if you see the chat and there's a question that you really want to see answered, click the up arrow, and so that it'll be scrolled to the top. So we've talked a lot about the GastroSAM study and implications. One other question was there a max fluid rate? So there's the 100 mils per kilo. Was there a max rate, or was it all weight based? I don't know who wants to answer that one.
So we did it according to WHO guidelines. It was we absolutely followed Plan C, and which was obviously terribly complicated, as Roberta's explained. But for it, it was weight based, and it was given as a standard rate over 8 hours for the slow rehydration.
Yep. So this could potentially be quite a very high amount of fluids, especially for the older children. So yeah, all weight based up to 100 mils per kilo in different time intervals depending on the
there was a question
trial.
about kwashiorkor.
We did talk about that while you were
while you were away, but
yeah,
feel free to add if you want.
Yeah.
No. I mean, including in the systematic review, we had quite a number of children who had been given fluids, and we found again in those children in the larger body of information that there wasn't any evidence of fluid overload. The myocardial function data that we provided, or I alluded to earlier on, again we had a large subgroup of children with kwashiorkor, and we found that their function was identical to children who were wasted myocardial function.
Thank you. So a question for Lizzie that I've seen raised before as well in terms of the statistics. The results were pooled in the IV arm against the oral. Can you explain the rationale for the pooling of the results for the IV arm?
So I think we felt we wanted both strategies in the trial because we were really interested in understanding some of the safety around them, thinking about how they had different amounts sort of going in at different time points, but in general the children would receive through IV a similar amount of fluid either at the end of 5 hours or 8 hours, but at the same time with a kind of restricted sample size given what we could recruit and what we could, that kind of sense. Given those balances, what we felt was for the primary outcome that the difference would be seen between those in the control, and combining those in the liberal arms, in both arms, gives us more power to see a difference if there was one. So that's why we did that. And I think, so it enabled this comparison of 134 and 134, 6, 8, I can't remember, that kind of bigger comparison, whereas if we'd had to do more tests to compare individual arms, we would have lost some of that. So that's why we did it that way, and I think worked well. But we got that extra information by having both of those strategies represented in the trial and implemented.
Great, thank you. And so I just switch now to the GastroSAM B and the implications for GastroSAM B and oral rehydration. So Kath, for you, do the results mean that low osmolarity ORS is clinically equivalent to Resomal, according to this study?
It's clinically equivalent in terms of many of the outcomes, but it actually has a lower risk of potentiating or causing severe hyponatremia at 8 hours, and that I think is potentially harmful. But the reason why it was recommended is that we were told that this was going to cause sodium overload, and so we looked for that, and in our parameters we didn't see that. So that reassured us that actually the concern that it was going to cause sodium overload. Thank you.
Now, Roberta, for you, there's some questions about what this means for policy and practice changes. One question that was posted was the role of WHO and whether WHO have endorsed these changes, and whether we're likely to see a change in policies, because most countries will follow WHO guidance. So I wonder if you could comment on that and tell us what do we need more studies? I think you've kind of answered that, but do we need more evidence, or do you think we're in a position now where we can reflect and make some policy and guidelines changes?
I mean, the answer is yes to both questions. Do we need more research? Yes, of course. Is this going to happen? Very unlikely. So is what we have enough to change policy? Yes, I think so. Of course, this is not the kind of change that we can do on our own with the people around the screen or even the people participating in this webinar. It's a very long process involving WHO. We are in touch with WHO, both the nutrition group and the pediatric group, to try to see how we can advance. It's a process that takes time. And as I mentioned before, and the sense somehow WHO really wants to provide recommendations that are based on solid recommendations, solid evidence, solid ground. And usually this implies having different studies proving the same outcomes in different settings. But again, we are working in contexts that are extremely complex, where this kind of studies are extremely difficult to run. So there is need to put together the evidence that is available with expert opinion and try to come up with something different. We are pushing for it. This is also one of the reasons why we do this kind of webinar, because we want to have as many people aware of the results. We also want to get feedback from colleagues on the field and see if what we say it makes sense to them. So I encourage everybody to get in touch. I've seen some comments already in the conversation around on the screen and supporting what we're saying, but I think field perspective is also important. And yes, the WHO is on the loop. We hope that a discussion, I mean, we know it's a complex period for WHO, so we cannot push too much, but the discussion is open, and we hope that it will lead to a formal reassessment of the recommendation soon. At the same time, as I said, this is already happening on the field. It was already happening before. Now GastroSAM gives more safety net for the clinicians to keep doing it. There is a certain hurry to provide standardized recommendation on how to give these fluids, because nowadays people are just doing it again based on local recommendation. I mean, discussion with colleagues, and I mean that's very difficult and it has been like this for quite a long time. So I think it's urgent. We know it will take a little bit of time.
Thanks, Roberta. There was also a question posted on caregiver perception and nasogastric tubes. I wonder, perhaps Dr. Ouattara, you can give us some insight into what that's like, and how did the caregivers perceive the management plans, and how in general do you feel like caregivers perceive, for example, nasogastric tubes and IV fluids?
Sorry, I was out for a moment due to the connection.
Did you hear the question? I can repeat the question.
Well. Yes,
okay.
Come again, please.
So there's a question in the chat. I'm rephrasing, but it alludes to the caregiver perception, and I think it's an interesting point, and nasogastric tubes particularly. But you were very closely involved on site, and I wonder, in your experience, what were the caregivers' perceptions like of the treatment arms, and what's your experience of caregiver perception of nasogastric tubes and of IV fluids?
Yes, for sure. The caregiver's perception on the nasogastric tube was not very good, because it's not very much accepted by the parent. They accept this, but they would like to see the child drinking themselves instead of having this tube put in there. And even the children, when they start to be very well awake, they wanted to remove it. And all the time, like Roberta said, you will see mothers replacing it for the babies who doesn't want to keep the nasogastric tube. So for the study teams and the teams there, everyone was much more happy and comfortable with the IV rehydration than the oral. I think this is what people prefer. whatever the slow arm was in the circumstance of a shock, people feel like it's a bit slow, but except that it's the most preferred rehydration in the field, because people, when you put it, you have 8 hours, you just do the surveillance, but you don't need to do recalculation, and it's really time saving, as mentioned by Roberta. So this is what I can comment. Thank you.
Joanne, I remember.
Sorry, go ahead.
Liz Molyneux, who's the chair. People probably know her very well from the ETAT guidelines, but she's the chair of our trial steering committee. She was very clear. She said mothers loathe nasogastric tubes, but they like IV lines. I know that's not evidence-based, but I think she's had so much experience. But
yeah,
she was
Elizabeth
very
Molyneux
clear.
almost is evidence-based, isn't she? Well, yeah, so we're in our final minutes of the presentation. It's been a fascinating almost 2 hours together, and I'd like to really thank our presenters. There's a big team, as you mentioned, Kath, behind this study, the trial team, but also all of the support staff involved, especially the teams on site. To conduct a study like this in these settings, they're already overwhelmed projects, and so the fact that this study managed to actually arrive at completion is a major achievement, and so thank you to everyone involved in the study. With that, I'll just go around and ask each of you for your one take-home message in sort of one phrase. If you can give us one take-home message from these studies, or one thing you would like to see change. I'll start with you, Kath.
Okay, I knew you would do. I think it's, I don't think there will be another trial. It's the fact that this guideline has been there for 30 years, and the fact that everybody has been petrified about giving IV fluids, and being told that the signs of dehydration are not reliable. If they were not reliable, then giving 100 mils per kilo to a child that wasn't dehydrated, we would have certainly overloaded them, but we didn't. So I think that there's a lot that we've learned from this, and I hope that the review of the information that's come from this, as well as the other evidence from IV rehydration and ORS, does result in a simplification and stopping differentiating severe malnutrition from non-severe malnutrition. One guideline.
Thanks, Kath. Lizzie?
Thanks very much, Johanna. I just think from a statistician's perspective, it was brilliant to see such high quality data, adherence to the protocol, all these things that really show the study was of really good quality and brought a lot of high quality evidence to the field, and it was a very challenging study. So from my perspective, I think it really shows a very high quality study with lots of really good data that's been collected.
Thanks, Lizzie. Ouattara, what's your take-home message?
Yes, I can just add that the study have proven that IV rehydration is safe, and that also WHO ORS, standard ORS, is also safe in malnourished children. We think in the field that this is a great opportunity to go ahead with the harmonization of different protocol that will really relieve the workload for the people in the front line, like said Roberta. So thank you very much. Yeah.
Thank you, Ouattara. And Roberta, I give the last word to you.
I would just say simple is beautiful. And now we have ground for a change in this direction. We can't wait any longer, and especially children and their family cannot wait. So I think we should really move forward, of course, with WHO, move forward with MSF. We have our own guidelines. It's not time to wait, because there's nothing else that's going to help us in this decision.
Thank you, Roberta. And I guess, from my side, above all, I think what this study demonstrates is that close monitoring and good nursing care saves lives ultimately. So with that, I'd like to thank all of you for joining and for your attention and input. But before we close, we would just like to take a moment to pay tribute to a friend and colleague, and I'll ask Mariana to cue the last slide. So we are heartbroken by the recent tragic death of Lucille Saint-Louis. As a physical therapist, she dedicated her life to caring for the youngest and most vulnerable patients, and she worked tirelessly to promote more comprehensive and humane care, particularly for children with malnutrition. She was an active contributor to Paediatric Days and generously shared her important work with passion and commitment. Her presence, humanity, and professionalism left a lasting impression on many patients, mothers, and colleagues. She left us doing what she loved to do, surrounded by a team that she deeply cared about and who cared for her deeply in return.